Hello and welcome to Season 2, Episode 6 of the Physician Assistant Exam Review Podcast. This week's episode is going to be finishing up Murmurs. Welcome back. My name is Brian Wallace. I am the host and creator of PhysicianAssistantExamReview.com and this podcast where we cover different blueprint material for the exam. It's really nice that the NCCPA has put together this lovely document outlining exactly what's going to be on your exam. Fortunately enough, that also sort of mimics what you learned in PA school, so it's good for end of rotation exams as well. They have their own blueprints. We're going to just go through the PANCE PANRE blueprints, and it'll still cover all pretty much the same stuff. So it works out really, really nicely that we have those documents to follow. I know some people get confused and concerned about the depth of the material to get into, how much to cover, what to cover. So one of the main things I focus on here on this show is the reasonable depth of study. You can get lost in the weeds and spend months and months learning intricate details. I mean, people get doctorates and on just very specific things, like, for example, the pulmonary valves of the heart. We're not in any position to do that right now. That's not our goal. Our goal is to pass this exam. In fact, my goal for this show isn't even to help you treat patients. That's really not my goal. Obviously, the outspring from the knowledge you gain will help you in that department, but that's not the goal of this program. The goal of this program is to help you pass your exam. I like to spend a lot of time on study tips, on ways to improve your scores, both in school and on your exam, ways to improve the way you get through and how you learn things. And then also covering some of the core content material to help you pass your exam. Again, so it's really not for me, and for this show, it is not about practicing medicine, diving really deep in certain topics. What I want to do is provide you with the right amount of information to make it so you can answer the test questions, but not bog you down so you get confused and lost. I feel like a lot of places, professors in particular, like to spend a lot of time going through tons of detail on things that, for our purposes here, you don't need. And I don't need to try to make myself sound smart by confusing you. I'd like to sort of take the really difficult things and break them down for you and make them easier and tease out the facts that are going to be important, the facts that will make it into test questions. Because certainly some information, some material lends itself to test questions, and some material doesn't. Some things are really hard to ask questions on. Some things are really easy to ask questions on. So I try to point that stuff out to you because, to me, that's the important thing. That's the key to passing exams and doing well on tests, especially multiple choice tests, when you know the format of the exam. Fill in the blanks are a little bit tougher. I used to drive me nuts in PA school when we would get those. But knowing the format of the exam, the multiple choice of it, makes it so much easier to study for and so much easier to figure out what possible things they can put on the exam. So we'll go in more and more into that as Season 2 progresses. I'm also looking into creating some other materials that'll help you in that department. It's in the very infancy stage now, in early 2017. Hopefully, I'll have some more information for you on that as we move forward. So what do we want to do? Let's start with our, what do we call them? The priming questions. This is one thing that I've learned that I found really to be helpful, is to set up a couple of questions at the beginning of what you're going to learn, or even if you don't know, you can sort of glance through the topics, through the titles, and put yourself together some questions if you're studying on your own, but things to get your brain working, to actively be working, not to just passively sit and listen, not to just passively be reading. So our priming questions for today, let's jump right into those. The tricuspid valve sits between which two chambers of the heart? The tricuspid valve sits between which two chambers of the heart? And again, here we go. This is something that you should seem really, really easy to you. And you're like, man, why is he covering this? This is so simple. The answer is, I like to think of this as the foundation, as knowing your multiplication tables, as things you don't need to waste energy on the day of your exam when you have to sit and think, wait a minute, is the tricuspid on the right? Is it on the left? Let me see the little mnemonic I had. No, I want it just drilled into your head so you don't have to stop and think about it. What is the cause of mitral valve stenosis? Mitral valve stenosis has more or less one major cause you need to know about. What is it? What patient What patient position improves your ability to hear problems with the mitral valve? So what I'm looking for there is it going to be standing, sitting, leaning forward, lateral decubitus, standing on their heads, laying on their backs, those sorts of things. What position improves your ability to hear problems with the mitral valve? And in this one, I made a little bit longer. You hear a murmur along the lower left sternal border of a 32-year-old IV drug user who is being treated for endocarditis. So there's a ton of information in there you should be thinking about. Left sternal border, 32-year-old IV drug user. And then it actually says being treated for endocarditis. You can probably throw the IV drug user part out since you already made that leap. The murmur is holosystolic, blowing, and radiates to the right sternum and xiphoid. He states that he has never had a heart murmur before today. What's the most likely cause of the murmur? And I'm not looking for endocarditis. I'm looking for what type of murmur is it? The murmur is holosystolic, blowing, and radiates to the right sternum of the xiphoid in a patient with endocarditis who has never had a heart murmur before. All right, we'll figure that out as we go. There was something I wanted to... Well, whatever. Let's just keep moving. Pulmonary valve. So last week we did the aortic valve. We started with just that, nice and simple, straightforward. We learned a little bit about the aortic valve, about valves in general. You should easily be able to name all 4 valves, their locations, and where you listen for them. That should all be stuff that you just have in your memory banks, really easy to work with. So let's start with the pulmonary. The pulmonary valve sits between the right ventricle and the pulmonary artery, right? So we're going to be pushing out from the right ventricle out to the lungs through the pulmonary artery. And again, we talked about last week, there's basically 2, as far as all of this stuff goes. And we talked previously about congenital defects like VSD and ASD, atrial septal defects and ventricular septal defects, and patent ductus arteriosus. Those are going to be a little bit different. You'll get more information about those as far as the age of the kid and so on and so forth. But for these, there's really 8 problems you can have, right? There are 4 valves that can each have 2 problems. You've got the aortic valve, the pulmonary valve, the mitral valve, and the tricuspid valve. Each of them can either have regurgitation or can have stenosis. They can either leak or not open enough. That's it. You've basically got 4 options. So let's start with the pulmonary valve and pulmonary stenosis. This is 80% of right ventricular outflow obstruction. So when you hear about right ventricular outflow obstruction, 80% of that is pulmonary stenosis. Causes here are usually, again, congenital issues, thickened valve leaflets, tetralogy of Fallot, those sorts of things. These are not things that you're going to see super common. Clinical presentation, most are asymptomatic. There is a murmur associated with these. The left sternal border in the left sternal border in the 2nd to 4th intercostal space is where you're going to find it. There is a crescendo, decrescendo ejection murmur without radiation. So it's an ejection murmur, so it's during systole. And you'll get a wide splitting of S2 as that valve takes a little longer to close to empty out the right ventricle. Right? If it's filled up with blood and it's pushing through a smaller opening, it takes a little bit longer. So S2, which is the closing of the aortic and the pulmonary valves, right? Those are our heart sounds. S1 is the closing of the mitral and tricuspid valve. S2 is the closing of the aortic and pulmonary valves. If you have a stenotic pulmonary valve, you get a split S2, meaning that the aortic valve closes just before the pulmonary valve. So it's almost like 2 separate noises there. This is heard best with the patient leaning forward, and a valsalva will enhance the murmur. Other issues with clinical presentation, these patients may be cyanotic, right? So if they're not pushing enough blood towards the lungs, it's not getting reoxygenized, and then they can get dyspnea and dizziness, obviously, along with that. Labs and studies, really, it's an echocardiogram is going to be how you diagnose pretty much all of this stuff, and at this point, that Doppler flow with the gradations is going to be how you diagnose all of this. You can actually see the blood flow back and forth through the valves and get a good idea of the pressure gradients and how things are moving. Treatment is going to be, like we said earlier, most of these are asymptomatic, so you can follow it with an echocardiogram every couple of years, depending on severity, and do a valvotomy, valve repair, or valve replacement. So our second issue with the pulmonary valve is going to be if it has regurgitation, if it leaks. Causes here can be things, again, congenital issues, Pulmonary hypertension, so if we've got an increased pressure, backflow pressure, that can cause a problem over time. Endocarditis, rheumatic heart disease, myocardial infarction, so damage to that valve, plaques, and then iatrogenic causes. On physical exam, you may find this on a routine medical exam. Mild cases are well tolerated and have few or no symptoms. So you may pick up this murmur on a routine medical exam. Severe cases may have right ventricular hypertrophy. Again, we're just trying to squeeze out more blood from that right ventricle. And severe cases may have right heart failure, obviously even a worse situation. For murmurs, here we have an early diastolic decrescendo murmur. Right, so we've got regurgitation through the pulmonary valve. It's going to be diastolic, right? So we just pushed out, during systole, we just pushed out the blood towards the lungs into the pulmonary artery. As we go into diastole, the blood is now flowing back through that valve into the right ventricle. So that's early diastolic decrescendo murmur. This is heard best with the patient sitting up and holding their breath at end expiration. So blowing out and then holding their breath will help you to hear this, and you'll hear it along the left sternal border, usually in that second intercostal space. And this may radiate to the right sternal border. Labs and studies. So an ECG here may show right ventricular hypertrophy. Again, if we've got that right heading toward that right heart failure. An echo with the Doppler is going to show most clearly and be the diagnostic tool here. And cardiac cath may be used. From what I've been reading, these are going more and more out of favor because the echo really is doing the job unless you want to go in there and blow up a balloon or something. Treatment. Pulmonary regurgitation is by itself well tolerated and typically does not require treatment. So it really, on its own, pulmonary regurg, not a huge deal. The valve may be replaced or repaired, but here's the big issue. The underlying cause should be addressed. So if they have pulmonary hypertension, if there's some reason or cause for this, that's where your treatment needs to be affecting. That's where it needs to head. So let's move on to the mitral valve. This is the mitral valve. The mitral valve sits between the left atrium and the left ventricle. One of the ways I remember this is there is an L in mitral and not in tricuspid, so L for left. Okay, so left atrium, left ventricle. If the mitral valve does not open sufficiently, you can visualize how the backup will eventually cause congestion in the lungs, right? Because we get a backup into the left atria, which backs up into the lungs, so that can cause us some major problems. All right, so let's move into mitral valve stenosis. Causes here, so you don't see a lot of mitral valve stenosis. It's a rheumatic heart disease is our main cause. That's the one that gets the bright red flag on everything I read, everything you look into. But again, we don't see a whole lot of rheumatic heart disease at this point in developed countries. Clinical presentation is a routine medical exam, exertional dyspnea with orthopnea, and perhaps paroxysmal nocturnal dyspnea secondary to pulmonary congestion. Again, you can get that pulmonary congestion. You can picture how the blood would flow back in, would have trouble getting out of the left atrium into the left ventricle and would then back up into the heart as the blood would be coming in from the lungs into the left atrium. And it would just have trouble as it pushed through, but it couldn't quite get through that stenotic tunnel. It would come back and push back into the lungs. On physical exam, so the murmur is an opening snap following S2. That tends to be that's an easy one to ask a test question on. An opening snap is mitral valve stenosis. It's heard best at the apex of the heart. That is the best place for most of your mitral valve issues is the apex of the heart. So it's the left midclavicular line. I think it's like the fourth or fifth intercostal space. But at the apex of the heart is where you're going to listen to for mitral valve issues. There's no radiation with this, so it doesn't go anywhere else. It is a decrescendo, crescendo, diastolic murmur. This is actually the second time I'm recording this because I got this backwards in my head. It's easy to confuse all these things. But if you have mitral valve stenosis, it'll be a problem when the blood is being pushed from the left atrium into the left ventricle, right? So it has to be a diastolic murmur. If you understand it and you can think about it, it'll make a whole lot more sense and you can catch those kind of problems. You're going to listen at the end of expiration in the left lateral decubitus position, and a Valsalva or exercise will exacerbate the murmur. These patients may display tachycardia, and if you listen to the lungs, you may hear rales secondary to pulmonary congestion. Right? We're backing up things into the right atrium. The left atrium. It's hard to get that blood out through that stenotic mitral valve. So the blood will push backwards into the lungs, causing pulmonary congestion. And that's where we get our paroxysmal nocturnal dyspnea as well. Labs and studies, ECG may show AFib. An echocardiogram is going to be diagnostic. Treatment, you would treat the AFib with cardioversion or warfarin. The pulmonary congestion you'd treat with diuretics or vasodilators. And then you can do percutaneous balloon valvuloplasty or a valve replacement if need be. Moving on to mitral valve regurgitation. This is when the left ventricle contracts, blood leaks back into the left atrium. An increase in preload and an increase in ejection fraction are what tends to occur there. Long-term causes this. In the long run, this causes an enlarged left ventricle and a decreased ejection fraction, and eventually leads to pulmonary congestion. Right, because again, we're just pushing more blood back the wrong direction into the lungs. Causes, this can be congenital. You can have degenerative mitral valve diseases. Mitral valve prolapse is the most common cause there, and this occurs most commonly in thin females. So again, to me, as I'm going through any of this material, I'm just jotting things down in my head that I would write test questions about, that I would look for. A mitral valve prolapse in a thin woman, that sounds like something that would be in a question stem that you may just ignore when you see that question, and it may not mean anything to you, which is okay, because if you don't know it, it's really not a big deal. It's not the only information they're going to give you, but it is a clue. The one example I give is in orthopedics, you get the slipped capital femoral epiphysis, and that's usually in an overweight, like 12, 13-year-old boy. They're not going to give you a skinny girl with that problem. So in this case, they're not going to give you a 60-year-old obese male who has mitral valve regurgitation. It just isn't really going to happen. So they're just these little clues that'll give you information towards the answer. Now, if you don't know it, if you miss it, it's not a big deal, but it just makes it much easier to retain that stuff if you can picture someone with that makeup, and then they probably will, again, not definitely, but there's a good chance you'll see a question written. If I was going to write a question, I'd include that just to make it a little more colorful, to make it a little easier to write. Moving along, rheumatic heart disease. Again, is an issue here for affecting the mitral valve. This is obviously less often than historically. Trauma can be a cause for mitral valve regurgitation. So if there's some damage to the heart valve, so an MI can cause damage to that heart valve. The big one that they always talk about here is the ruptured chordae tendineae. This is caused by an MI or endocarditis. Endocarditis in general can cause an increased risk for regurgitation and damage to that heart valve. And then a cardiomyopathy, if you're stretching things out, that may begin to leak. That was like aortic regurgitation. Just that widened space will make that valve not close as tightly. Clinical presentation. These patients may come in for a routine medical exam. Both mitral prolapse and regurg may be asymptomatic for years. And like all this stuff, they can get exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea secondary to pulmonary congestion. So none of that stuff is going to help you determine which murmur it is, which problem they're having, right? They all have exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. So as much as it's nice to know that stuff for your clinical practice, that's not going to help you determine which heart problem a patient's having in a test question. Our physical exam findings for mitral regurgitation is a pansystolic blowing murmur at the apex and radiating to the axilla. So again, our issues with the mitral valve are going to be at the apex. This one's going to radiate to the axilla, and it's going to be all throughout systole. Because as we increase that pressure inside that left ventricle, that's when we're pushing the blood back through that mitral valve in the wrong direction, and that's going to be during systole. The patient lying in the left lateral decubitus will help us. This will decrease with the Valsalva or standing and increase with the hand grip or squatting. You may find an S3, which will push you toward thinking about heart failure. And mitral valve prolapse has that mid-systolic click. Again, just a really easy question. I would be shocked if you would see that on your test, because it's something that just is a really low-hanging fruit, like already on the ground type fruit, but something it's so easy. Well, you should know it at this point. They may also have a brisk carotid upstroke, and once again, real secondary to pulmonary congestion, depending on how bad the situation is. Labs and studies, they may have AFib again. They may have left ventricular hypertrophy, so you could see that on an ECG. You'd wind up getting a Doppler for your diagnosis, and that would give you the complete picture of the severity of the issue. For treatment, again, the AFib would be treated with a cardioversion and warfarin. Pulmonary congestion would be diuretics or vasodilators, and then you could repair or replace the valve. So a lot of these, they're not going to make you necessarily parse out treatment plans, right? Because they're all kind of the same. Repair or replace the valve, monitor the patient with echo over time. That's not going to be what the questions really are. It's going to be more identifying the type of murmur based on the patient's description, based on the description of the murmur. That's the kind of things you're going to have to do on your exam. Moving into the tricuspid valve, this valve sits between the right atrium and the right ventricle. Tricuspid regurgitation is caused by right ventricular hypertrophy. The tricuspid regurgitation also causes right ventricular hypertrophy, just to confuse things a little bit. But if you think about it, right ventricular hypertrophy, if we stretch out that ventricle, we're going to change the shape of that valve. And if we change the shape of that valve, it's not going to close as tight, so you're going to be able to get some backflow through it. Pulmonary hypertension, often caused by left-sided heart failure, will also cause tricuspid regurg. Ebstein's anomaly, which is a congenital heart defect with displaced tricuspid leaflets. So if you picture that those 3 leaflets of that valve, if they are thickened, if they're in a weird arrangement, they're just not going to hold up as well. So you're going to get some regurgitation back through them. You can get tricuspid prolapse, and endocarditis is another one here. So basically anything that's going to, endocarditis is going to come up a lot because anything that damages, or an MI, because anything that damages those valves can give you regurgitation in particular. Clinical presentation, again, exertional dyspnea. Here you can get some chest pain, swelling of the feet and ankles, and neck pulsations due to increased jugular pressure. So here we have a clinical presentation that is a little bit different, right? You get some chest pain. You get some swelling of the feet and ankles. You get those neck pulsations because you've got blood once again flowing back in the wrong direction, but this time out to the vena cava, out to the body. So you'll get some increased jugular pressures, all that swelling, that kind of thing. All right, so physical exam for tricuspid regurgitation. Let's start with a murmur, which is going to be along the left sternal border. It is hollow systolic, blowing, and radiates to the right sternum and xiphoid. Again, that tricuspid regurg, if you think about it, right ventricle contracts, pushes the fluid back through that tricuspid valve. So it's going to be a systolic blowing murmur that radiates to the right sternum. And it's heard best with the patient sitting up. Another physical exam finding you may have is that jugular venous distension, right? I talked about that a little bit earlier. You may see that and some swelling in the legs. Labs and studies. An ECG may show normal P wave due to enlarged right atrium. Abnormal P wave due to enlarged right atrium. ECG may show abnormal P wave due to an enlarged right atrium. Chest X-ray may show an enlarged right atrium. Echocardiogram with Doppler is going to assess all this, and a cardiac cath, again, may be used for some more information. Treatments: diuretics to decrease fluid volumes, salt restrictions to decrease fluid volumes. If pulmonary hypertension is a problem, you're going to want to treat that with arterial vasodilators, and then surgical valve repair or valve replacement, depending on, again, the severity and what's going on there. Sweet. So that finishes up our valve disorders, our valve issues. Let's jump into our study tip for today. What I want to talk a little bit about here is attitude. I was reading through some things, and they were talking about, I've read before that obviously the more interest you have in a subject, the easier it is to learn it, right? So if you're paying attention, if your brain's turned on, if you're actively engaged versus if you're arguing yourself about why you're even there, that can make a tremendous difference in the amount of information you retain and the amount of information that gets into your brain. So if you're sitting here thinking, I can't believe I have to learn all this. This is so dumb. This doesn't have anything to do with my job. I work in surgery. I plan on doing only dermatology. Why do I need to know this? I can't believe I'm here. Versus someone who is going through the material saying, geez, it's really cool that I get to study medicine, that I'm around people who want to study medicine, that I get to learn all of this stuff. I really enjoy these aspects of medicine that I don't get to do anymore. Like for me, I like cardiology. I don't do any cardiology in my practice. I'm a surgical first assistant. I spend 5 days a week in the OR. And so I see the ECGs on the screens from the anesthesiologist, but I don't have anything to do with it. So I think it's fun to go back through. Fun might be a strong word. I like learning cardiology. I like going through that material. I think it's I just find it interesting. And if you can find a way to make it interesting for yourself, it will make a tremendous difference in how much information you retain, in what you can learn, and even in how fast you get through the material. If you sit in a room and tell yourself and tell your brain that this is dumb and you don't need to know it, then your brain will check out. It'll say, okay, good. I don't have to know this, so I'm done. And it'll switch off and it'll cool off, and you will not retain and you will not remember, and you'll struggle to get through the material. But if you dive in and can create a situation where you can create some interest one way or another, where you can turn it into something that you want to learn, even if it's just for not in an end of itself, but if it's for getting through the PANCE, if it's getting through something, to say, geez, I can't wait till I'm done with this. Let's jump in, and I'm going to do the best I can to break through and really get to know this stuff. It'll make a huge difference in how quickly you can tackle the stuff. But again, in what you retain the next day, your brain will just dump the stuff right at the back as soon as you walk away from the books, if you tell it to. And that's what you're doing when you spend that time complaining and moaning and groaning about what you have to learn. The bottom line is, in order to get your certification, you have to learn the stuff. It doesn't matter what your interests are, whether you think it's important, whether you don't think it's important to you. At the moment you're studying for your exam, none of that stuff matters. What matters is you have to learn it. Now, you can make other choices. You can choose not to get your certification. People do that. You can choose to work with the NCCPA or the AAPA and try to get it changed. Lots of people are doing that. That's all great and fine. And you can have those opinions. But in the moment that you're preparing for your exam, you need to let all of those opinions and all of those negative attitudes about the exam and about the information you're learning, you have to kind of put them on hold. You have to create a positive, interested attitude, and it will make your studies significantly easier. All right, so that's enough for me for now. So let's move on to our priming questions. Let's get to the answers for those. The tricuspid valve sits between which two chambers of the heart? The right atrium and the right ventricle. That one should have been easy from the start. What is the cause of mitral valve stenosis? History of rheumatic fever is what I was looking for there. What patient position improves your ability to hear problems with the mitral valve? Left lateral decubitus. We mentioned that twice. The left lateral decubitus for mitral stenosis and mitral regurg. That'll help you there. And if you recall, what was our location for listening to the mitral valve? It's over the apex. You hear a murmur along the left sternal border of a 32-year-old IV drug user who's being treated for endocarditis. The murmur is holosystolic blowing and radiates to the right sternum and xiphoid. He states that he has never had a heart murmur. What is the most likely cause of the murmur? So which of our 8 would it be? In this case, it's tricuspid regurgitation. All right, great. So that pretty much, well, not pretty much, that does wrap up our episode 26. Like I said, thank you so much for tuning in. I am so excited to be back. The outpouring from the last episode was fantastic. I have a lot of people very excited that the show's restarted, for some people just in time, which is great. And that has really been amazing. I also just want to encourage you once again to sign up for the email list. That's where I will pass along so much more information than what I can get to here. I actually wind up writing there almost daily. It's 5 days a week right now, and cover study tips, rotation tips, things you can do on your rotations, things you can do when you're looking for a job, things you can do to help you prepare and make studying easier, better, faster, test-taking tips, all of that stuff. I go into greater detail in the emails than I do here in the show. I'm also working on some other things that I think you will find very interesting and very helpful moving forward. And the way that I communicate those ideas is much more easy to people who are already on the email list rather than waiting 2 weeks for the show to roll around. So if you're on the email list, you'll definitely get information on anything new coming out well before the podcast airs. So you can do that very easily by heading over to the website. There's lots of ways over there to sign up. And also, if you are listening and you just won't, and you don't ever go on a website anymore, that just seems like something that doesn't happen as frequently, you can get on the email list by texting PA exam, all one word, to 33444. The number is 33444, and you text PA exam to that number, and it'll walk you through a couple quick, easy steps to get you signed up and get you on there and start getting all that great information as soon as possible. So until next time, good luck to anyone taking their exams this week. Please let me know how you make out, and we'll pick up, I think we're going to be finishing cardiology at the next episode, or maybe it'll take us 2, but we're just about there. So take care, and I look forward to talking to you again next time. Good luck.